Good morning. It's my pleasure today to continue the workshop of CKD, how to retard the progression. So this is the second part, and in the first part, I discussed the introduction, definition of CKD, and why CKD is an important disease, risk and contributing factors for chronic kidney disease, and its progression, the impact of age, gender, hypertension, and diabetes on CKD progression. Today, and this is what the first part that was recorded in 1 hour, and today I'm going to discuss with you some other risk factors for chronic kidney disease progression. Acute kidney injury is a real risk for incident CKD. The second, obesity and nutritional aspects and their correlations with chronic kidney disease and progression. Gut-kidney axis, physical activity, smoking and chronic kidney disease, hyperuricemia, and lastly, in this second part, I'll discuss sleep disorders and chronic kidney disease. To start with, I like to ask you, Dr. Muhammad, some questions, and I need to hear from you. Is the statement true or false? So just I want to hear true or false, and at the end of the presentation, I repeat the same questions and to answer them with some explanation. Okay?
Okay.
The first statement, for recovered acute kidney injury is a risk factor for chronic kidney disease.
True.
Acute kidney injury increases the risk of reduced GFR, but not proteinuria.
False.
Weight loss is protective against chronic kidney disease.
False.
NAFLD, non-alcoholic fatty liver disease, is associated with chronic kidney disease.
True.
Spicy foods help in reducing salt.
False.
Tinabanor use is associated with salt and water retention.
False.
Why? Do you know tinabanor?
Yeah, I heard this information before, but
You don't remember? Okay. Constipation, contrary to diarrhea, is not associated with chronic kidney disease.
False.
The evidence of using hypouricemic drug is clear to protect against CKD in asymptomatic hyperuricemic individuals.
True.
So let us to start with acute kidney injury. There is a relationship between acute kidney injury and occurrence of the future chronic kidney disease. May be explained by the epigenetic changes that can occur with acute kidney injury. How? Acute kidney injury is associated with capillary rarefaction that interact and leads to hypoxia. And hypoxia interact with the genetic makeup leading to DNA methylation, histone modification. All these are epigenetic changes that can be followed by interstitial fibrosis and chronic kidney disease. So this may be a link. Why I'm interested in mentioning all these details? Because in the future we may find some research conducted to address the efficacy of targeting capillary rarefaction, hypoxia, or epigenetic changes to guard against the occurrence of chronic kidney disease. Nobody knows. In the future we may have research. Regarding the issue of acute kidney injury and occurrence of chronic kidney disease, this is a study about post-discharge kidney function after acute kidney injury and its association with subsequent 10-year renal progression risk among survivors of acute kidney injury. This is a very interesting data. The study included, this is the number of patients included, AKI in 1,966 cases, in no acute kidney injury in 12,000 cases. Here, if you look, this is one of the figures within this article, which is very interesting. Look here. Here, if we don't have acute kidney injury, if there is no acute kidney injury, and this is if there is acute kidney injury, and after the acute kidney injury episodes, kidney function recover completely to a level exceeding 60 milli per minute. What do you see? Here the percentage of those who will develop 30% declining. These are already patients who developed declining 30% of GFR. As you see, the presence of acute kidney injury is bad news, and it's associated with subsequent development of a reduction of estimated GFR and chronic kidney disease. So even if acute kidney injury completely recovers, we should keep eye on these patients because there is a risk for subsequent development of chronic kidney disease. So this is one of important point. And this is the same data here, no acute kidney injury. The hazards here is the reference, and if there is acute kidney injury, the risk for chronic kidney disease in the future is doubled. So we should be cautious about the acute kidney injury and the risk of chronic kidney disease. So that all nephrologists should ask the patients about the previous history of acute kidney injury or admission with acute kidney injury, especially if the acute kidney injury necessitated dialysis. And even if the acute kidney injury recovers completely, we should take care of these patients because there is a risk for development of chronic kidney disease. Another very interesting article linking acute kidney injury with future proteinuria. So the article is entitled Acute Kidney Injury as the Risk Factor for Subsequent Proteinuria. It included 600,000 patients, and when they analyzed the patients into matched cohort, including 181,000 patients, 90 in acute kidney injury group and 90 in no acute kidney injury group, they found that if there is acute kidney injury, as you see here, there is increasing the risk for proteinuria. So you can see here, if there is acute kidney injury, subsequent occurrence in the baseline, no difference between no acute kidney injury and acute kidney injury, but after 1 month, you will find increasing risk of development of proteinuria, and here after 2 months up to 1 year, the presence of acute kidney injury is associated with subsequent development of proteinuria. This means that there is a link between acute kidney injury and subsequent development of chronic kidney disease. The question, can we predict the development of chronic kidney disease after acute kidney injury episode? This one of the articles is showing this, and this is the number of patients included in this study, and this is a very smart predictors. So we should ask about the age. If it is in this range, it is 0. If above 50, it's 1, etc. So you can follow every variable and look at the scoring for each part of the variable. Sex, for example, this is for men and women. So you can go all through these variables. At the end, you will find a total score. If the total score is in this range, between 1 to 8, this is the risk for chronic kidney disease. The higher the total score of this risk prediction, the higher the percentage of occurrence of chronic kidney disease. So it is important to know all the details of the patient. Some of the important risk factors for chronic kidney disease is the effect of intensive blood pressure treatment on acute kidney injury. So if we treat blood pressure aggressively and the patient witness a reduction of kidney function in the domain of acute kidney injury, this is bad news. So we should be careful. And as I mentioned in the first part within the hypertension sector, that the intensive blood pressure control may have benefit for the survival and cardiovascular, but regarding the incidence of chronic kidney disease, intensive blood pressure control may be associated with higher incidence of chronic kidney disease. And this is a call for individualization of treatment and follow up our patients meticulously. As you see here, this is the incidence of the acute kidney injury after intensive blood pressure control. Another important point in the acute kidney injury sector is if you have a patient with chronic kidney disease, is this patient more susceptible to chronic kidney disease? The answer is yes. Why? Because in chronic kidney disease, there is abnormalities in the epithelial cells, and all these are the molecular and the basic abnormalities and mitochondrial dysfunction, autophagy disturbance, excess inflammation, and abnormal vascular function or vascular dysfunction. So all these are different mechanisms that lead to heightened injury and suppressed repair, and then subsequent chronic kidney disease, acute kidney injury on top of chronic kidney disease. So in this point, chronic kidney disease is a risk for acute kidney injury. In the previous sectors, the acute kidney injury is a risk for chronic kidney disease. And the title of this review is Acute Kidney Injury on Top of Chronic Kidney Disease. It is a state of heightened injury and suppressed repair. And if you want to read the mechanisms in detail, you can go to this article, which is very interesting. And I think in the future, we should have workup and research to target the development of drugs that can halt the progression from acute kidney injury to chronic kidney disease. As you read in this article, drug discovery to halt the progression of acute kidney injury to chronic kidney disease, a case of phenotypic drug discovery in acute kidney injury, and it is an interesting article. So to summarize this sector of the presentation, acute kidney injury is a real risk for chronic kidney disease, and we should be careful about other risk factors if we are dealing with a patient with chronic kidney disease, because so long as the patient has chronic kidney disease, this increases the risk of acute kidney injury. So acute kidney injury can lead to chronic kidney disease, and the chronic kidney disease increases susceptibility to acute kidney injury. Regarding obesity and nutritional aspects, this is from the ISN Atlas of Kidney Global Health, Kidney Health Atlas. You can look here at the different the prevalence of different body mass index. Obesity is defined if body mass index exceeds 30 kilogram per square meter. Look at the color here. Here, Egypt. Here, the prevalence of the obesity, body mass index exceeding 30 is between 10 to 20. So here and here, if you look at the Gulf area, Saudi Arabia, it exceeds 30%, and Emirates. Okay, so this is the map of obesity. There is a relationship between obesity and chronic kidney disease, either directly, so adiposity leads to disturbance of all these mediators, leading to inflammation, etc., that can lead to chronic kidney disease. Or, so this is a direct link of obesity with chronic kidney disease. The indirect relationship is obesity is associated with diabetes, hypertension, and cardiovascular disease. All these factors can increase the risk of chronic kidney disease. So obesity leads to chronic kidney disease either directly or indirectly. And this is another article showing the same. Fast food is associated with many problems that at the end of the day can lead to chronic kidney disease. And this is another article discussing the issues from basic science. So here you can look at all these. So excess visceral adipose tissue can lead to all these mediators, including pro-inflammatory, release of adipocytokines, early secretion of factors for monocytes recruitment. So all these are factors, other factor in cellular dysfunction, other factor RAS activation, increasing vascular stiffness. So all these factors can amalgamate together and leading at the end to tubulointerstitial fibrosis and chronic kidney disease. So this is all these are within the same domain that obesity is associated with chronic kidney disease. It's not only obesity, but metabolic syndrome can be associated with chronic kidney disease. So this figure summarizes the issue of obesity and metabolic syndrome together, leading to chronic kidney disease. Regarding non-alcoholic fatty liver disease, this is one of the articles here in the participant in the study. The study included 41,000 patients. The presence of non-alcoholic fatty liver disease is associated with increased incidence of chronic kidney disease, as you see in this figure. We are interested in this issue to the extent that we have currently MD thesis about the fatty liver and chronic kidney disease and kidney dysfunction, because fatty liver is not isolated liver disease, and there is systemic manifestation, crosstalk between fatty liver and other system dysfunction. This is systematic review and meta-analysis. In this systematic review and meta-analysis, NAFLD, non-alcoholic fatty liver disease, detected by biochemistry, fatty liver index or ultrasonography, is associated with nearly 40% increase in the long-term risk of incident CKD. So this is the link between this. Regarding the issue of weight loss, this is an important study here, association between weight loss, kidney function decline, and risk of end-stage kidney disease in chronic kidney disease in children cohort study. So here, as you see here, the red land or red lines refers to significant weight loss and weight gain. So if there is here, if there is significant weight loss, the unadjusted odds ratio, for development of end-stage kidney disease is increased. So, and here the weight gain is associated by the same. So both weight loss, and I think it is unintentional weight loss, because CKD may be associated, this may be an association, may be associated with poor nutritional parameters. So unintentional weight loss may be bad, and weight gain is bad too. So this is the point. Regarding the issue of low protein diet, high protein diet increases the risk of hyperfiltration. Why? Because high protein diet leads to afferent vasodilatation and efferent vasoconstriction. This is why if we adopt the low protein diet, but to be careful against the development of protein energy malnutrition, this will ameliorate afferent vasodilatation. So low protein diet will lead to increasing the afferent vasoconstriction, and in the same moment leads to efferent vasodilatation. So low protein diet attenuates the effects of protein on the hyperfiltration or hydrostatic pressure. So this is why the low protein diet is associated with lowered hyperfiltration injury. And all this slide summarizes the potential benefits of low protein diets and the challenges and risk of low protein diet. So regarding CKD progression, the low protein diet is associated with synergistic effect with angiotensin pathways modulator to lower intraglomerular pressure, as I mentioned before. So this is an advantage. So and you can just fix this slide and read it in details. Also, it may be there is consistent antiproteinuric effect which may mitigate hypoalbuminemia. And here the issue of acid load from the protein is ameliorated by low protein diet. So you can look at all these advantages and challenges. This is another study. They addressed the association of a low protein diet with a slower progression of chronic kidney disease. In this study that included 1,594 patients. And the issue I want to ask you, Dr. Muhammad, about the issue of red meat. What's your opinion regarding the encouraging red meat for chronic kidney disease? Is consuming heavy red meat is good friend or foe?
I don't think that consuming lots of amounts of red meat is associated with the progression of chronic kidney disease.
So if you want to advise your patients, you advise them against red meat or to consume red meat?
I will advise them to consume moderate amounts of red meat. I will not prevent it completely from them.
This is the data, Dr. Muhammad. This is the meat. If you look here, this is the calories, protein, lipids, saturated fat, cholesterol, iron, sodium, phosphorus, potassium, magnesium, zinc, vitamin B12, and selenium for the different sources: beef, veal, pork, and lamb. So you can look at the constituents of the red meat. At the end of the day, red meat, yes, includes the high biological values amino acids. This is an advantage, but all these are disadvantages. saturated fatty acids, uremic factors, cardiovascular disease problems, sodium, phosphorus, increasing risk of proteinuria, abnormal lipids, increasing oxidative stress, and inflammation. So this is why we are against the encouraging red meat. So for the renal health, from renal nutrition perspectives, it's better to avoid red meat. We can encourage protein intake through other sources, but red meat is maybe harmful for our patients. This is why Mediterranean diets, that one of the important points in Mediterranean diet is restriction, major restriction of red meat, and to consider supplementing protein from other sources, because as I show you, that red meat is not a friend. Another nutritional risk index in geriatric age. This is how the geriatric nutritional risk index is calculated by this equation. And in this study, the lower the tertile of this index, the higher the risk of CKD progression. So this is the dialysis-free survival. So the highest curve, the best curve, because this is dialysis-free. And this is the third tertile of the geriatric nutritional risk index, which is a high index. Another way of considering the nutrition. Regarding salt, are you with salt restriction, or you are not convinced by salt restriction?
I agree with salt restriction.
How much restriction?
Um,
Do you encourage sodium-free diets?
No, not
Or-
necessarily. I encourage to consume less than 6 grams per day.
6 grams
6 grams per day.
sodium
Yes.
or sodium chloride?
Sodium chloride.
So regarding sodium, how much sodium? Because usually when we say sodium, when you say sodium chloride, it is double the sodium. So 6 grams means 3 grams sodium.
Yes.
Okay.
Less
So-
than 3 grams.
If you look at this study included some persons who are hypertensive and some who are not hypertensive, and they address the issue of quartile of sodium. So sodium intake either less than 2 grams per day, this means sodium chloride 4, or between 2 to 3, or 3 to 4, or above 4 grams sodium, this means 8 grams sodium chloride. The results, this table shows this is a multivariate Cox proportional hazard regression analysis, creating an association between dietary sodium intake and the incident of chronic kidney disease. The relationship between salt and chronic kidney disease is within hypertensive group, and there is no significant difference in non-hypertensive group. And the interesting point here, if you look here, for the first quartile and for the third quartile, there is increased risk of the chronic kidney disease with hypertensive individual. So we should be careful about that. So the first quartile is associated with higher risk, and the highest quartile is associated with the higher risk too. And if you look at, if you consider the third quartile as the reference, for the first quartile for a person aged less than 60, and for female, and for those who are obese, the first quartile, this means the very low sodium, less than 2 grams per day, and very high sodium, above 4 grams per day. Both of them are associated. If you look here, this is the p-value, significant difference here for quartile 4 and for quartile 1. So the message is very low level of sodium and very high level of sodium are associated with chronic kidney disease in a hypertensive patient. So this is why we should consider the salt restriction. Because if we review our food, you'll find that we are consuming a lot of salt. So this is a call for salt restriction. And when I say salt restriction, to less than 5 grams per day sodium chloride in the range of 3 grams sodium. Okay?
Yes. Okay.
What about tinabanor? Do you hear about it before? It is the drug that can work here in the intestine. So in the intestine, we have sodium hydrogen exchanger system. So if you block it by the tinabinol, so sodium will not be absorbed by the intestinal cell. This means sodium, we get rid of sodium through the intestine. But the problem of the use of this drug, it may be excess diarrhea. So we are waiting the evidence from clinical research to prove the value of tinabinol in. I think it will be valuable for patients who cannot comply with the advice of salt restriction. So it can help us. Regarding the issue of spicy foods, this commentary that was published this month on the Journal of Hypertension, and very interesting, because this was our advice to the patients before, but we don't read in details. So here it seemed that encouraging spicy foods works on the frontal cortex that reduces the craving for salt. So replacing salt by spicy foods can help a lot the patients to get rid of excess salt intake. So it's beneficial to cut the salt. Another important point in the dietary recommendation is the use of fiber, to encourage fiber. Fiber is important, and there are many advantages for encouraging fibers, especially if we are dealing with the patients in the early CKD. The issue of hypovitaminosis D, it is very interesting because there are many functions of vitamin D, i.e. pleiotropic effects of vitamin D, as in improving endothelial function, improving blood pressure, improving uricemia, reducing the issue of inflammation, the immunology aspects, anti-cancer, CKD progression. All these are the expected mechanisms of vitamin D. However, up to this moment, the evidence is not strong, and we are waiting further studies to confirm the association of vitamin D therapy to guard against CKD progression. So we are waiting further evidence from the coming studies. Regarding folic acid, there is a link between folic acid and retarding kidney progression, because folic acid deficiency can either directly lead to all these: increasing oxidative stress, superoxide generation, decreasing nitric oxide, increasing myocardial problems. So all this can lead to CKD progression directly, or folic acid through hyperhomocystinemia can lead to all these parameters. So it seems that folic acid may help us, but we are waiting also studies in this domain. The concept of acid load. If we are consuming the hard processed cheese or heavy protein, red meat, all this can increase acid production, and this is an acid load. And as you know, with chronic kidney disease, there is a problem of acid-base balance. Okay, so and the encouraging fruits and vegetables are associated with bases and alkyls. To the extent if we encourage fibers and fruits and vegetables in the early beginning of stage 1 and 2 chronic kidney disease, even the potency of this diet may be equal to sodium bicarbonate supplement. Okay, but the problem of consuming protein, fruits and vegetables is hyperkalemia in advanced chronic kidney disease. So if we are smart and intelligent, it's better to start earlier by encouraging this type of food. And this is the problem of high acid load. If we are looking at high dietary acid load, this will lead to muscle catabolism, increasing ammoniogenesis to get rid of the acid, and excessive ammonia within the renal tissues is toxic to the kidney and increases inflammation and fibrosis, so it's bad. The decreasing renal cortical pH and increasing bone absorption. At the end, you'll find progressive kidney disease and other problems. So we are against this issue. This is why it seems that Mediterranean diet is suitable for our patients. The Mediterranean diet, these are the features of Mediterranean diets: provisional of a healthy protein and fat intake aligned with CKD recommendation. Here, predominance of vegetable and fish protein versus meat protein. So this is one of the main component of the Mediterranean diet. Predominance of monounsaturated fatty acid over polyunsaturated fatty acids. The polyunsaturated fatty acid over saturated fatty acid. So this is the component favoring consumption of olive oil, high dietary fiber intake, high fiber intake, moderate carbohydrate consumption, low glycemic index and glycemic load. So if you read in details, you'll find that this diet is interesting for our patients. This is a consideration. If you look here for meat, for a Mediterranean diet, white meat 2 times per week. This is according to the recommendation of Mediterranean diet. Red meat less than 2 times per week. In fish, 2 times per week. For legumes, 2 times per week. For dairy products, so you can read the details of Mediterranean diet. It seems that it is interesting. And if you look at plant and animal protein, yes, animal proteins include high biological value amino acids, but on the other arm, the animal protein include excess salt, excess acid load, etc. So this is why I consider plant protein at the green land and the animal protein of red land. And you can look here, the calories is less in plant and high in animal protein. External amino acid not complete, here this complete. Saturated fat is here is low in plant, and we don't like saturated fat. We encourage unsaturated fat. Fibers are high in the plant protein. Iron, sodium, potassium. Sodium is low in the plant protein. The problem is high potassium, so this is why in advanced CKD it is better to monitor serum potassium or to start the plant protein in the early beginning of chronic kidney disease. And this is the quotation, no disease that can be treated by diet should be treated with any other means. I think it is a wisdom. And this is the general recommendations of nutritional parameters in chronic kidney disease. So the protein to be in this range, and you can hear the lowest value is between 0.6 to 0.2 gram per kg per day, and this sodium less than 3 gram per day, and the potassium and phosphorus, calcium, etc. Regarding the issue of diet soda, do you know if there is any problem? Because the title of this article is Diet Soda Consumption and the Risk of Insulin in Stage Renal Disease. Is there a link between diet soda and development of chronic kidney disease progression and stage kidney disease?
I think that diet soda might be associated with hyperkalemia and advanced end-stage renal diseases, but the association between the diet soda and the incidence of end-stage renal disease, I'm not quite sure.
This is an interesting study in the general population, and they found that the higher the consumption of diet soda, the higher the risk of end-stage kidney disease. And the explanation is either because of metabolic abnormalities, or because of acid load, or because of disturbance in the gut microbiome, and other mechanisms are discussed within this article. So we should encourage the people against diet soda, especially those who consume a lot of the cups of diet soda. And if you look here, this is the categories of diet soda consumption, glasses per week, less than 1, 2 to 4, 5 to 7, above 7. As you see here, the hazard risk increases by consuming the diet soda. So should be careful about these issues. Regarding the plastics, this is a very interesting statement that is written as a paragraph within this book about the plastics. Evidence suggests that bisphenol A, which is used in the manufacture of plastic food and beverage containers, which are commonly found in foods and a broad array of consumer products, produce inflammation and oxidative stress. So plastic increases the issue of inflammation and oxidative stress. Urinary metabolites of phthalate and bisphenol A have been associated with microalbuminuria and increased blood pressure in children in the United States. Avoidance, this is a statement and message, avoidance of plastic containers and processed food decreases the exposure to these chemicals. So I think it is interesting data. And this is why I am very happy and proud that we have nowadays in Mansoura Renal Nutrition Fellowship program, and these are the colleagues within the task force of renal nutrition, and we celebrated 1 year. So currently we are 13 months after the establishment of this program. Okay, regarding blood kidney axis, I start with this statement: constipation and chronic kidney disease. Is there a link between constipation and chronic kidney disease? Although the evidence came from this observational study, it is a retrospective cohort, including 3.5 million persons, and they found the presence of constipation is associated with increased risk of chronic kidney disease. And the higher the degree of constipation is associated with higher risk of chronic kidney disease. This may be cause of abnormality in the gut microbiome, we don't know, but this is from the data. So as you see here, if there is constipation, look at the figure, Dr. Muhammad, the cumulative probability of incident CKD increases if there is constipation. Not only this, but also the cumulative probability of incident intestinal disease. And the severity of the constipation dictate the degree of chronic kidney disease. So here, absent, mild, moderate, or severe constipations are associated with increasing scales of the incidence of chronic kidney disease and the end-stage kidney disease. Regarding the issue of gut microbiota in CKD, this is very interesting because we have in the gut many bacteria reaching the very big figure. And the presence of the microbiota within the gut is associated with protective effects, nutritional factors, immunological effects, metabolic effects, structure and function of the gut integrity, and the most important for us is the renoprotective effects, reducing kidney damage, decreasing infiltrating immune cells, decreasing apoptosis, decreasing levels of reactive oxygen species, and etc. So this is the association of gut microbiota and chronic kidney disease. In chronic kidney disease, there is a state of dysbiosis. Dysbiosis means abnormality of the gut microbiome within the CKD environment. And the abnormality of gut microbiota or dysbiosis increases the risk of generation of uremic toxins, and all these problems increase the inflammation, etc., that increase the risk of chronic kidney disease. And if you want to read all the details of gut microbiome abnormalities and chronic kidney disease, this is one of the slides that is already within the SNT Virtual Academy by Professor Elbaz, the microbiome and CKD, an overview on November 2016, followed by this presentation. You can find this on the Virtual Academy and this on YouTube, regarding the gut microbiome and the progression of chronic kidney disease that I recorded this year. And the last presentation that you will find on the Virtual Academy is for great Professor Prof about the microbiota in nephrology, an update that was presented on Nephro Alexandria July this year. So on all this presentation, you can see how the abnormalities of gut microbiome is associated with chronic kidney disease, and how to handle the gut microbiome to reduce the effect of dysbiosis on chronic kidney disease progression by either prebiotic, probiotic, symbiotics. So it is very interesting to review all these slides. Regarding the issue of physical activity, we should encourage physical activity because a lot of publications about physical inactivity and the problems within the blood pressure, within the kidney disease, stones, etc. So we should encourage the physical activity. And this slide shows the lower the degree of physical activity, the higher the scale of fertility and the problems even reaching mortality. And this is one of the important reviews about the physical inactivity as a risk factor and a target for intervention in renal care. So we should encourage all patients for exercise. So we can examine the patients, determine the capacity of the patient to tolerate exercise, and to build up exercise as we can. Even for patients on dialysis, we should encourage exercise because exercise in these patients improve muscle bulk, quality of life, anemia, bone strength, etc. So this is the lesson. And here we are speaking about CKD progression. Yes, there are many data showing that physical activity ameliorates the progression of chronic kidney disease. And here, the physical inactivity is associated with excess mortality and many problems. This is why, at the end of the sector of nutritional and physical inactivity, I'd like to put this slide. Although it is extrapolated from hypertension guidelines that was issued early this month, in November, sorry. And this, if you look here, encouraging weight loss, heart health diet, DASH diet, sodium reduction, potassium supplementation, increased physical activity, all these are essential. As you see, all these are recommendations based on level A evidence for managing hypertension. Here for potassium, why potassium supplement is important for the patients? Do you have an explanation, Muhammad?
Potassium supplement is important for the patient because of it's important for the myocardial activity.
One of the important points, Dr. Muhammad, is potassium supplementation overcome sodium problem. So some of the important points to combat the bad effects of sodium is to encourage potassium intake. But the problem in advanced CKD is the risk of hyperkalemia. So if we are smart, we should start early. So start early by encouraging the natural source of potassium, fruits and vegetables. This will improve the issue and ameliorate the effect of salt. Okay? Regarding smoking, this is the map of smoking. If you look here at Egypt here in the moderate land, between 20 to 30% of Egyptians, adult Egyptians, are smokers. Again, smoking is, this is my statement, smoking is kidney poison. We should state this statement for all the patients who are coming to the outpatient of nephrology clinic. Smoking is considered a kidney poison, affecting all the structure of the kidney. And in the past, I have lectured about that. But here, even for the issue of progression, this is a study that showed that cigarette smoking attenuates kidney protection by angiotensin converting enzyme inhibition in non-diabetic chronic kidney disease. In this study, smoking ameliorates. If you look here, this is a non-smoker, and this is a person who quit smoking. So quit smoking is beneficial to reduce urine albumin creatinine ratio. And this is again, we should encourage the urine cessation of smoking because it is healthy for the kidney. And so we can conclude the sector of smoking that smoking is poison for the kidney and is a chronic kidney disease accelerant. So we should advise against smoking. Regarding the issue of hyperuricemia, hyperuricemia is bad and associated with progression of kidney disease, either non-diabetic or diabetic, etc. And here, as you see, the cumulative incidence of CKD increases because of hyperuricemia. Again, this is the same data showing that hyperuricemia is associated with many problems. Here, the higher the quartile of uric acid is associated with kidney failure, so this is a fourth quartile. If it is above 8.7, the risk of renal failure increases, and as well as death. And the relationship between uric acid and death is U-shaped curve. So both very low level of uric acid and very high level of uric acids are associated with excess mortality. This is a very interesting article discussing the issue, uric acid predicts adverse outcome in chronic kidney disease, a novel insight from trajectory analysis. This is very interesting data showing this, the issue of the correlation of uric acid and its trajectory with kidney disease. Even asymptomatic hyperuricemia, it is bad also because associated with risk of stone kidney disease in this large cohort of Korean adults. So again, this is the data showing the link of uric acid, as you see, with the stone. So it is increased among men. This among men and this among women. The risk is very evident in men. So hyperuricemia in men is bad news and increases the risk of stone formation. And this is one of the studies showing that using the febuxostat may be potential, even more than allopurinol, as a renoprotective effect, but the evidence is not convincing for me. And there is a warning about the febuxostat and the cardiovascular mortality that was issued early this year, early this month, and another data showing the febuxostat induced myopathy. So we should be careful about the reading. Regarding the issue of impact of uric acid levels on kidney disease progression, this is a very interesting and smart study. Why smart? Look at the curve of progression. So this is estimated GFR after a period of follow-up. Here, which is the worst? The worst is the red line. Sorry, the best is the red line, because this is with all this follow-up, the GFR is still very nice. Here, if you look at the green color, is using uric acid lowering therapy and the low level of uric acid, and the bluish one is using uric acid lowering therapy and high uric acid. So it seems that, and the last one, the last color is no uric acid lowering therapy and high uric acid. What is the message here? The message, uric acid is associated with progression of kidney disease, but the use of uric acid lowering therapy is not associated with amelioration of the trajectory of the kidney function. So it seems that yes, there is association, but no causation. This is why in this article they encourage to change hyperuricemic induced kidney disease into hyperuricemia associated with kidney disease. So it seems that hyperuricemia is surrogate and not the cause. And this was a debate in the Damanhur this year. Professor Barsoom delivered a very interesting presentation about uric acid. Is it friend or foe? And yes, there are many aspects of friendship and non-friendship, because uric acid is considered antioxidant, anti-inflammatory, immune stimulants, etc. But if it increases, and especially if it's intracellular, it can lead to problems. So uric acid, yes, it is friend in some aspects and foe in some aspects. So it is like yin and yang. You can find white and black. And after his presentation, Professor Barsoom ran a debate either to treat asymptomatic hyperuricemia, yes or no. So Professor Muhammad al-Khatib from Cairo University defended yes to treat asymptomatic hyperuricemia, and Professor Ahmed Adam, his presentation was there is no evidence for using hyperuricemic drugs to treat asymptomatic hyperuricemia. At the end of the debate, Professor Barsoom announced that Professor Adam won the debate, because still up to this moment, although you can find one article here or there showing the beneficial effects of hyperuricemic drug, but up to this moment there is no sufficient evidence toward the routine use of hyperuricemic drug for these patients. And because the hyperuricemic drug may have side effects, even if you want to treat, you should monitor your patient well. The use of febuxostat in the advanced CKD is not approved, and may be associated with myopathy or rhabdomyolysis. So should be careful about the use of this medication in a stage 5 CKD. So this is why the evidence for using hyperuricemic drug is not enough, it's not sufficient. But myself, I am with treating asymptomatic hyperuricemia by using non-pharmacological treatment. So non-pharmacological treatment for all persons with asymptomatic hyperuricemia, and to restrict the hyperuricemic drug until we have a good evidence for that. And this is the same message from the Cochrane Review Group. Here, they reviewed 12 studies, including 1,187 participants, and the evidence for the use of hyperuricemic drug was of very uncertain benefit. Regarding the last sector in this presentation, which is sleep disorders and its correlation with CKD progression, this is a study showing addressing the issue of association of sleep duration and quality with CKD progression. Here, as you see, this is the estimated GFR milli per minute, and this is the sleep duration, either more than 6 or less than 6. What you have, here the indecision disease event rate per 100 person per year increased in the black color. This means that few hours sleeping and excess sleep fragmentation and abnormality of the score of sleep, all these parameters of poor sleep are associated with progression of chronic kidney disease. So this may be due to sympathetic abnormality, we don't know, but we should encourage healthy sleep environment. This is the same data, but about the mortality. So abnormality of the sleep, low quality sleep, few hours of sleeping, and fragmentation of sleep is not only associated with CKD progression, but associated with excess mortality. Again, I'd like to repeat the question with you, just to say true or false, and now we'll discuss the choices. For recovered acute kidney injury, the risk factor for CKD, true from the publication that I mentioned, that there is a link between the occurrence of acute kidney injury and subsequent development of chronic kidney disease. Here, either with the GFR criteria for CKD or with proteinuria. So the presence of positive history for acute kidney injury is bad news. It's associated with increasing risk of chronic kidney disease and proteinuria and subsequent history. Weight loss is protective against CKD?
No, it is excessive weight loss, the same as excessive weight gain, might be associated with CKD.
Here, the statement is not precise, and I think if it is intentional weight loss for obese person, may be beneficial, but if weight loss is unexplained, unintentional, this may be a problem because it may be associated with CKD progression. So we should compare and fine-tune this statement. Renal, non-alcoholic fatty liver disease, yes, it's associated with CKD because there is the crosstalk between excess fatty liver and the chronic kidney disease. Spicy food, yes, here because it ameliorates the tendency for craving for salt, as I mentioned. Tinabanor is associated with salt and water retention, no, because it helps us to get rid of salt through the intestine. Constipation is contrary to diarrhea, it's not contrary, it is the same, associated with chronic kidney disease because it may reflect the abnormality of the gut microbiome. The evidence of using hyperuricemic drug is clear, it is unclear.
It's unclear.
So it is a wrong statement. So this is the end of the second part, and I hope that within this week I can record the third part of this presentation because I consider CKD and CKD progression is the core job of nephrologists, and if we succeed, even just to retard, slow the progression of chronic kidney disease, I think this will be a great job. In the third part, I will discuss other factors for chronic kidney disease progression, metabolic acidosis, and I'll discuss the new concept of subclinical metabolic acidosis, how to diagnose it, and what is the link between metabolic acidosis and chronic kidney disease. Drugs, in very brief, I'll mention 2 or 3 examples about drugs and CKD, the progression of polycystic kidney disease, risk factors and prediction, and some other risk factors, a cocktail, like pollution, like monocytes, counts, etc. And then I'll go through the advances in research, in basic research and molecular medicine in the issue of chronic kidney disease progression before I reach the concluding statement. So I'll be happy if you have any question to send to my email. Thank you very much for your attention and hoping that you find it is an important topic. Thank you very much, Dr. Muhammad.
Thank you.